My name is Amy Bravo. I am the Chief Operating Officer with Youth Recovery Connections here in Hollister, California. We're out of San Benito County. And with me today is Michael Salinas. He is the Executive Director of Youth Recovery Connections, a program basically inspired by our lived experience and our professional experience and everything that we saw from a CBO perspective to a county perspective, and addressing those treatment barriers that we're seeing, especially with our youth. We've had an increase in youth overdoses. We just had a 14-year-old overdose about 2 weeks ago, followed by another overdose, the same individual. So two overdoses in 2 weeks and of a 14-year-old, with many more youth in our area. So the need for addressing health disparities locally and in the Tri-County is a need for us on the Central Coast right now. And so this is a hot topic among public officials and families and school districts, all those who work with youth. Next slide, please. So today's topic is implementation or engaging youth who are in MAT. It's a little different. Again, I am out sick, so I would like this to be as collaborative as it can be. So if you would like to leave a question or comment in the chat box, we can go ahead and address those in real time. If you are in the rooms today in Sacramento, hello, I wish I could be with you guys. I bet it's even hotter out there. So make sure you guys have a nice cold Coke after this for me, because I'm dying over here. And then I think they have it set up for you guys to ask questions. So feel free to jump in at any time and ask a question as you see fit. Next slide, please. A little bit of housekeeping. None of the presenters, Michael or I, have been coerced, paid, or planned any kind of business practices or marketing strategies to participate in today's session, and no distributing healthcare products used by or on patients. Next slide, please. A little shout out for National Recovery Month. I hope that you guys and your agencies are making a statement. Social media has blown up in our area with different events and campaigns for Recovery Month. Next slide, please. Here we are, youth engagement and MAT. Next slide. It's kind of hard. Again, I'm not there to read the room, but you guys drop in the chat, what is your scope of practice? Are you clinicians, providers, prescribers, administrators, substance abuse counselors, peer supports? I just would like to get a feel of the audience. If you guys can drop in the chat, provider champion.
Nice.
Do we have any sons here working under the bridge? Not marketing manager, social worker, nurse, SUDS counselor.
Nice.
Whoop, whoop, Santa Cruz.
There you go.
Okay, you're a neighbor. Nice. There's a little mix. Perfect. Because it's obviously important that we have a team approach, right? So brainstorming and sharing ideas of what works and what doesn't work is very important. Knowing the mission of your agency and who the stakeholders are, the change agents in your community, getting political buy-in, especially with youth. We were, under the circumstances, fortunate enough to have the community support. The community actually was the driving force behind a lot of our work, and supported any efforts from prevention to MAT that would support their youth locally. So it was hard but easy at the same time, getting on the agendas for board of supervisors, city councils, and whatnot to move forward with our project. I can, real quick, Beth, I can't see the slides. They look, I'll use this one. So I'm just going to take you over the DMC ODS versus Cal AIM. as you all know, I think everybody is knee deep in CalAIM and trying to figure out what the heck is going on. Some counties better than others, and some of us are still learning how to crawl, even though we feel like we're running the CalAIM Olympic race. So real quickly, I don't want to go down too deep of a rabbit hole. The goals of CalAIM is to identify and manage comprehensive needs through a whole person care, right? Integrating mental health and substance abuse under the umbrella of behavioral health. We want to look with improve quality outcomes, reduce health disparities, transform the delivery system through value-based initiatives, payment reform, and make Medi-Cal a more consistent and seamless system for enrollees to navigate. That especially if you're enrolled in both mental health and substance abuse, navigating those two together to work seamlessly for the whole person has been very difficult for the beneficiary. Just across the board, DMC ODS, there are some changes that create new opportunities, and then some that just change the workflow a little bit. New programs under CalAIM are in enhanced care management. We have community support for services. For example, those are people or persons experiencing homelessness that maybe have a comorbidity, say they have a substance abuse and are experiencing, maybe they're doing chemo for cancer, or some type of, or they don't have a safe place to relax and rest after their chemotherapy treatment. Not forgetting those demographics of people that need extra support, dialysis. They have to go every other day for dialysis treatment, or patients that test positive for TB. We've had some people in our NTP program that tested positive that had to go to, and it's like a managed care home, and they have nurses there 24 hours giving them their medications for 30 days. Short-term recovery supports, sobering centers are new initiatives, housing supports. I don't want to go down too far into that, but key changes to existing programs under CalAIM, behavioral health reform. That's the biggest one. Aligned incentives on integrated care for seniors and people with disabilities. More flexible payment for public hospitals that care for the uninsured.
This doesn't matter to them.
So that's just a little brief. And then the model care for foster youth, in getting foster youth into the care.
She's asking if there's but we're not billing the MCOs.
We've got a quick question in the chat, if that's okay. We have a question from Kristen. We are at FQHC. We are not billing with DMC ODS for our SUD treatment for youth. Is the slide talking about inpatient, IOP? We're just hoping for a little clarification.
FQHCs are a little different because your reimbursement rate is higher. So you want to stay with FQHC billing because the DMC ODS fee for service return would be less than you would get for FQHC. I hope that answers your question. And we just met with the hospital yesterday, so that was fresh in my mind about FQHCs. But a really good resource too would be California Bridge. I can get the contact, maybe Grant, and send it off later, and you can send it out.
Sure,
California
absolutely.
Bridge has a really good team of experts and provide TA opportunities for FQHCs as a partnership with the ED when they're doing the Bridge program. And I just met with them yesterday, so that might be a really good resource for you moving forward as far as billing too. And next slide, please. I can't see the slides, guys. It looks like transformer writing. So I have to go with from my memory.
Sure. So the slide's on youth engagement, some strategies, and some barriers, if that helps.
So I'm going to pass it to Michael. COVID brain's kicking in.
So my name is Michael Salinas. I'm an executive director for Youth Recovery Connections, as Amy mentioned. So happy to be here today, guys. Unfortunately, we couldn't be there in person. Amy's a little sick, and I just wanted to make sure that I wasn't sick before, going and spreading this virus. So again, our apologies for that. We're super excited to be here. This is definitely a big thing for us. This is huge for us. And I think, just being able to kind of get out here and talk about the youth is that's what's the most important part here. Amy and I've been working together for about 7 years now, and the different organizations, and we finally decided to build our own organization, and here we are today. So again, hence Youth Recovery Connections. I definitely, have a passion for working with youth. It's something that I really take pride in. Because I am one of these youth. So I definitely would like to go above and beyond to try to help these guys as much as they can, girls as well. So with that being said, Amy and I actually, we implemented MAT outpatient in Monterey County. We actually started the first youth program out there under a different umbrella, but we had the opportunity to do so. And we had a doctor there that was prescribing buprenorphine. So it was just amazing to be able to kind of see the outcome of these kids when they're actually getting the medication and how it's working for them. Of course, it's going to be a little bit different than, rather than you're, prescribing to an adult. There's a lot more consents and a lot of that other good stuff, policies and procedures and everything else that it goes with. However, it's the end result has always been good with medication. I mean, I'm a huge supporter of medication, for treatment for opioids. I think it's a wonderful thing. And yeah, so I think for me, what it is, I kind of wanted to talk about, the engagement and some of the things that we've done, and I think that works, and it may not work for everybody, but I've kind of pretty good rapport with most of the guys that I work with and young ladies. So I think the most important thing to remember is kind of, we have to think outside the box. We have to think about, this is a different population and this is a different world today. With that being said, it's kind of like, we have to be able to kind of meet them where they're at, in a sense, and kind of, educate them the way that they're going to understand. I mean, from my experience, I've seen when adolescents go into offices and they're kind of hearing something that's just, they don't know what's going on, and they end up losing them in the first 3 minutes. I've seen it multiple times. So for me, it's always been a little bit easier to, when they come in and kind of just engage them the way they're going to understand, talk to them the way that they're going to understand, because they need that for them to understand, a lot of these adolescents, they come from different walks of life, and I think that's important to take into consideration as well. There's just so much when it comes into adolescence, and I definitely, study, everything I can and learn different ways to kind of improve, the quality of care for the adolescents, because like I said, it's important to me. So we talk about strategies, I think, because we're, moving into CalAIMS, I think, experts going to definitely be a big thing, for CalAIMS. So I think just utilizing experts to identify and refer to the proper level of care. I think that's a little bit rough these days, guys. I mean, we really don't have too many residentials, when it falls under DMCS and ODS and now CalAIM, which is not okay, but that's just kind of what it is. I know that in our area, we have absolutely no residentials for youth that accept, Medi-Cal services. And so they're kind of left with the level 1 or level 2.1, outpatient or intensive outpatient level of care. And unfortunately, that doesn't work for all of them. I would say about 90% of the adolescents that I've worked with thus far meet criteria for a residential program. And unfortunately, we don't have that many resources. And so they get stuck doing a level 1 or level 2.1 outpatient or intensive outpatient. So that's something I think that, we can improve on, as providers. I think that's something that we should definitely bring to the table. I think it's really, really important that we do so. Especially now with this fentanyl, and even worse, of this new drug that I've been hearing about that's, a lot worse than fentanyl. We really need to figure things out as a provider, and I'm hoping that in the future we'll be able to do that. Again, expanding the network of providers. I think we just kind of talked about that, prescribing, and then it's kind of like, we do have, I mean, it's a little bit, I think it's a little bit better now. However, when Amy and I started this, the MAT for youth, it was super difficult to find a doctor that would prescribe. There wasn't many doctors that would do so, and it just made it a little bit difficult for us to be able to do our jobs. We finally got a doctor that was willing to do it, and it worked smooth after that. But I think it's important to be able to kind of find we need an influx of doctors that come in and just are able to provide prescribe a medication for the youth. again, engagement, meet them where they're at. That, to me, that's just really important because of the fact that that's what we have to do. And if it means, kind of taking it down a level and kind of just to make sure that they understand. I mean, that's just kind of the way that I do things. I guess I'm a little bit different, but they truly do understand, and they're definitely going to take treatment a lot more serious than they would have if you're trying to tell them something they don't understand. Barriers, connect with medication without parents' consent. I mean, that's a little bit of a barrier, but I think we got to take into consideration that it could definitely turn into a mess if we don't have consent from parents, and if they're not actually the ones that are keeping track of the medication. However, I have ran into problems with adolescents where they're like, I don't want my mom to have that. I don't want them to know anything, but I mean, that's my medication. I want to take it. I know how to take it. And then it becomes a little bit of a battle, but at the end of the day, I mean, it's we need to do that. It's secure practice. We need to follow that and make sure that the parents are actually not only consenting, but actually giving the medication to the adolescent when they need it. Lack of providers that are willing to practice, we talked about that a little bit. I'm hoping that that's gotten a lot better. It's been a couple of years since Amy and I, embarked on that mission. We haven't dove in there yet at our program now. So I'm not really quite sure, how many providers are out there actually doing this. And I'm hoping that there's a lot more, so that way when we do decide to get back in, maybe be a little bit easier than it was the last time.
Michael, do you mind if I ask a quick question?
Sure.
I'm just curious if you have any tips or recommendations when working with the parents, maybe the parents or working with the youth who's afraid to tell their parents and get their parental permission. Do you have any tips or recommendations or things that you found helpful about how to navigate those conversations?
So yeah, I think again, I think for most youth, they are a little bit standoffish of explaining what kind of substances that they're using. They definitely don't want to tell mom and dad everything. It's kind of like I've been smoking a little bit of pot, but that's all I'm doing. I'm not doing nothing else. However, when we get down to the nitty gritty, it's a lot more than that. So I think the most important thing is just to kind of engage them in a way that they're going to understand that parents they're a huge asset when it comes to recovery. I kind of engage them in a way to kind of, explain like, mom and dad are going to be huge in your recovery. Mom and dad are, they're very much needed in your recovery, and I'm going to tell you why they're needed, and kind of just explain to them, exactly why they're needed and how big the support factor is in recovery. And they might be standoffish for a little bit, but I say you give it a few weeks and you keep on engaging them the right way and explaining to them the way that they're going to understand again, that parents are very important in this process. They've always gotten parents involved, so it's been good. As far as parents, actually they've gotten a lot better these days, to be honest. I think what it is the fear, right? I think a lot of this comes from fear. They're afraid that their children are gonna, I hate to say this, but they're gonna pass or they're gonna die from this horrible drug, right? And that's enough to scare any parent. That's enough to scare me. And so with that being said, I think they're more open and they're more honest about everything now. It's kind of like they're not holding back anymore. They're not protecting their children. They're not, this is kind of what it is, and this is what my son or daughter needs help with, and we need to address this immediately. And they're a lot more engaged. It's a lot different now than it was, a couple of years back, to be quite honest with you. A couple of years back, we still had parents that are hold on to that stigma, not my son, not my daughter, no, not them, and now it's kind of like, no, yes, my son and my daughter, you need to help them. So I think that plays a big role in the engagement with the parents.
How many of you guys already have an existing MAT program for youth, or are you trying to implement a new program for youth? If you guys want to leave it in the chat or jump in the rooms, I think they have a microphone set up so I can hear you guys if you go to the podium. I just want to get a feel of what direction to take this conversation. Yes, for adolescents and young adults. When I just commercial break, when I was the executive director of a narcotic treatment program in Salinas, when the opioid epidemic really took off. And so we were able to partner with or receive assistance from UCLA and Boston's Children's Hospital. And actually, when I took the leadership team and prescriber out to Boston and worked hand in hand with Boston's Children's Hospital and learned about different prescribing regimens, I guess you guys would say, and what it would look like for patients to receive medication-assisted treatment and the different parameters around that. So we have, yes, MAT for the last couple of years. We have PEDS. True story about PEDS. And in building the program, we met with a lot of stakeholders, and one of them was the pediatric department at our county hospital. And just having conversations with the pediatricians about asking questions. So when the kids come in for their annual, this would be, I guess, for Eugene, when the kids come in for their annual physicals for school, have you implemented said questioning into those physicals? So this was about 4 or 5 years ago. We met with Natividad, and once we started working with the pediatric department, we saw a huge influx in referrals based on just a couple questions added to the physical forms. So that's another way, is to really evaluate who your stakeholders are, from the hospital, ER to pediatrics. Juvenile justice is another one. So yeah, that is where really our program first took off in Salinas, in implementing MAT with our youth. And I think almost immediately I didn't realize how many youth. We've been working with adults so long, you just get in this routine of care and you don't even realize the struggles that are going on with our youth. So long story short, my niece is from San Benito County. I got custody of her in Monterey County. She reunified with her dad in Santa Cruz County, and she passed last year from a fentanyl poisoning, and she was 15 years old. So quickly, my motivation, right, for, here you are thinking you're serving adults and you're making change in the world, and, people, you're saving lives and not even realizing what's going on in your backyard. And so, Michael says it all the time, and I steal his story, that, addiction and mental health don't sleep. It's a 24-hour a day crisis. I always explain that the clinic is like an ER for addiction. There's always something happening. It seems like every day, 6 a.m., ambulance is there, or something's going on, CPS cases, new charges, police showing up. So it's more than just giving the patient a medication and performing a service, right? So you get invested in really having strong boundaries and performing, knowing your ethics and not getting wrapped up too much, because it's not like an outpatient or a residential where they come and they go, and you might not see them again for a year or two, and then they might relapse, right? Come and go. And then, but for NTP clinics or kids that are on medication-assisted treatment, it could be for years. We have people in the clinic 20 years they've been on MAT. So it's like, it's kind of hard not to know about their dogs or your kids or the grandkids, and take it personal when somebody passes. So youth has really touched my heart. Michael as well, being a former youth, obviously, and his experiences with the juvenile justice system and foster care system, and if there were programs like this, wraparound services back then maybe a few lives would have been changed. So let's get into medication-assisted treatment. Remember, I'm not a doctor, I'm not a prescriber, though I pretend I am, or I act like I am. I'm not. Just been working in the field for a very long time. Excuse me. And all I can speak to as what we have done at our previous clinic and what is in our strategic plan here for our new site, and how we do that. So again, it's really up to your county and the actual provide the site and your policies and procedures, what that will look like as far as the prescriber. Remember, it is their license that they're prescribing under. And so I'm very communicate very well with the providers and what they're comfortable with, and educating and always having that continuous education. When we first started, it was more like the old school doctors have a different mentality of patient care, and really training the new residents and doctors of what incorporating addiction into medicine And just watching that evolve. I come from a medical background with my family. And so just hearing stories growing up and seeing how even bedside manner has changed, and really feeling sympathetic for the person who's experiencing substance abuse. We got to remember, again, Michael talked about stigma and how that, correlates with what's going on in their life. We did not do, we did buprenorphine, obviously, for our 16 and over. We did not do any type of medication younger. However, some agencies do. In Boston, we learned that there was a 12-year-old, again, it was a cancer patient, though, that was addicted to opiates at 12 years old. And so that individual did start, and it wasn't buprenorphine, it was a methadone program at 12 years old. But again, there were special circumstances around, surrounding the cancer and the medications involved. As far as opioid use disorder for illicit street drugs or prescribed medications, 16 and over for buprenorphine. We did do naltrexone. We started off with the pills to make sure that they weren't didn't experience any kind of adverse reaction. Once they were stable for a month or two, they went to injectables. We've had 2 now on naltrexone. All the kids have been on buprenorphine. The youngest one, again, was 16. We did not do, and this was all done in an outpatient setting. Even though we had an NTP clinic, we did not have any of the youth enroll into our methadone program. However, we did receive the appropriate certifications and clearances from DHCS and the feds to be allowed to do that. Should the need arise, we were able to provide that. However, it was in leadership's opinion that we would try to stay away from that as much as possible. However, you can treat for severe opioid use disorder with multiple overdoses. You can put a youth into an NTP program on methadone, but again, I would cross that bridge very carefully and what your provider is comfortable with in your agency. All medications need consent for minors. Even though in our program, we have minor consent for treatment as far as outpatient IOP and recovery services. It's almost like Planned Parenthood, and you have a pregnant teen, they can come in and receive confidential substance abuse services. But anytime that there's a medication involved, you have to get parental consent and cannot prescribe otherwise. And pretty much, I guess you guys are all prescribers, so you understand. Does anybody have any questions? We even give our youth bracelets when they get the injectables that state, there's a lot of education that goes on with the medications, obviously. And they have the little bracelets that they wear. They become proud of their bracelets. It's almost like a unofficial contingency management program. We'll say, let me see your bracelet. And they get like a little, gift card at the end of the month if they have their bracelet on all month. So we kind of make it fun and collaborative. And they come in
the room. Amy, we do have a question in the room. Sorry to interrupt.
I was curious about, so I'm Holly, I work in Santa Cruz in a at Janus substance use disorder treatment center, and we have an NTP clinic. Are there any protocols for the distinction between, like, when one would use methadone, prescribe methadone, or are there medical providers in the group that know of any work that's being done around that?
So it's been a couple years. I don't recall off my top of my head, but I know there's protocols because I've read them. We just decided as an agency, there's always the minimum standard, right, that you have to, provide. And then you can either provide higher but you have to provide that certain level. So even though it was acceptable and we went ahead and got the clearance to do so, we did not, as an agency, prefer to add that as a service. I mean, we could and capable, just in case of emergency, something crazy happened, I don't know. We didn't want to ever turn anybody away, but didn't want to advertise that that was what we were offering and felt comfortable doing. And it was not just, you know, me as leadership, but the provider, the board of directors. I mean, it was a collaborative decision not to go ahead and give methadone. And this was 3 or 4, I mean, this was in we launched our program in 2019, and that was just the way the policy was. And it has been with our audits with the county and the state. Unless something has changed since 2020, that is what it was then. I can go ahead and I'm taking notes on the side. I can go ahead and get that information for you and send it to the IT here, and they can send it out. I mean, there's always extreme cases like Boston Children's Hospital, but that is given in a hospital setting. You know, it's a little different than you would do in an NTP clinic for sure. There are rules too about having minors in the same lobby as adults. We had to have separate entrances. The youth could not come in the same entrance, or could they, we had to dose them at different times. So that was in our policy as well, even though we never had a youth in NTP. So they couldn't dose during the same hours as adults. They couldn't enter through the same entrance as adults. They couldn't loiter inside or outside. They had to have transportation from, you know, to the dose or the session or, you know, appointment they were coming to, and immediately after were not allowed to stay on property. And that was highly revised our policy to make sure we got the language right with DHCS. So I know that was important for them to know that there wouldn't be mingling of the 2 different ages groups. Pros and cons of MAT. I think, so again, you know, stigma is going to be something we always fight to the end of time. Anybody that works in NTPs, outpatient, any type of drug treatment in general, we are always fighting stigma. And as soon as you think you got a step forward, it's like you take a step back. And so medication-assisted treatment for adolescents is more than just MAT. I think we need to provide the whole continuum of care from detox. And so what we are doing here with this first program initiative, if you will, is starting a substance abuse response team. And I think that if we can, just looking at studies and data, in which we don't really have a lot for youth, and that's another thing is if your local county or if your county has done a needs assessment recently and what the data is showing for your county, is it sustainable? How many youth, you know, could be enrolled in treatment versus how many providers and staff you have? We are in a shortage as far as prescribers and clinicians and SUDS counselors to even, you know, support what's going on in our local counties. So that's already is a hardship in trying to combat opioid addiction. Of course, with any kind of medication, it's the cravings, right? The cravings and looking at what's going on in the environment as well. Prevention can play a lot if you have prevention programs. Play a big role. All of our kids have reported, when I first thought, like, we started the program, I was like, oh, the kids, this is going to be so great. And, you know, we're going to have fun with the kids. I didn't realize that one youth is like 6 adult clients. I mean, you're dealing with the schools, you're dealing with truancy, you're dealing with probation, you're dealing with police and out past curfew. It's like, it's not just substance abuse. You're dealing with family, you're dealing with trauma. You know, ACEs is another one with CBER. Like, everybody needs to have an ACEs now. In really understanding substance abuse counselors and mental health understanding SUDS and SUDS understanding mental health as far as how trauma plays a role in substance abuse. And I thought, this is going to be great. This is going to be fun. And it's been the most difficult thing I've done professionally is understanding what the youth are going through. I would say 98% of them have some type of trauma, and not, I mean, just horrific trauma. And so you have to practice self-care as a counselor and a clinician to be ready and have those resources ready. We've had kids involved in sex trafficking, date rape, just incest, molestation in the home. It's just a lot. Food disparities. Another thing we have implemented is like we partnered with the food pantry. Didn't partner with them. They would give us donations, and because the kids would come hungry, they would come after school, and especially with COVID, suicide, rates were higher, domestic disturbances were higher. All these kids now that would escape by going to school or at home with their parents, right? And the abuses went up, and food disparities. So we had a little, it started out like a little snack table, and it turned into like a little pantry of snacks and food. And then the kids just wanted to hang out. And then it turned into like a little mini homework youth center after school. And so it's really being able to adapt your programming and your workflows to what the needs of the community are and the kids. So it's not as simple as an administrator just to, I know sometimes I can get in the mindset of, okay, we're looking at costs versus, trying to mitigate risk and all these things that go on with being an administrator. And then we have just wanting to help the kids. So you have to constantly be innovative and forward thinking of how you can address drug or substance abuse with our kids and incorporating the parents. Family interventions is super important. You can't treat the whole person if you don't consider the environment. And so we've done a lot of surveys with our kids, and we've just increased our hours. Traditionally we're used to working, 6 to 2 or a 9 to 5. And the kids are like, those are the hours that we're okay. We need like a 11 to 8, 12 to 10. We need somebody open till midnight, because those are the hours after school is when the temptations come, when the cravings are the worst, or when the gang, they're out in the street, their friends or negative environments are enticing, and particularly most of when our overdoses are happening, at least locally. So we've changed our hours to accommodate that, and we're open until 10. And then we have 10 p.m. and then we have an on-call. So they can call the phone if, a hotline if there's an overdose or something's going on or they need support with. So we've addressed a lot of different barriers for the youth that they're reporting as barriers in an attempt to curb the substance abuse.
Okay, guys, I just wanted to kind of jump in a little bit and talk about again, just to kind of touch on the pros and cons. I think, one of the pros of medication-assisted treatment is the fact that, we're using the harm reduction approach. A lot of kids, they come in and they're going to tell you that they can't stop using, because they can't. It's for them, they've been doing it maybe for several years and they just don't know how to just stop, and just let's face it. I mean, if you tell an adolescent to stop, they're going to tell you to stop. And you try to push, they're going to push back. That's just the kind of the way that it works, with the younger crowd. So I think that's huge, just the fact that, medication assisted treatment is actually helping with that, and instead of saying stop, it's kind of like, we can do this to help you, assist you in recovering from this substance, but in a different way, fashion and form. Right. So that's definitely a big thing, for the kids, because they don't know how to just stop, and it's easy for us as parents sometimes to say stop. But for them, they don't understand just stop, and they can't even comprehend that. So, I think that's huge. That's one thing that medication-assisted treatment brings for the younger crowd. Again, just to be able just the fact that they're able to kind of, deal with the cravings a little bit better. I had one of my kids that just got into buprenorphine about 3 weeks ago, and this was his first time ever trying it, and he was just like, oh my God, he's like, I wish I had this a long time ago. I wish I would have done this a long time ago. And he was, he felt better like immediately. I mean, I don't know if it was just a head thing for him, honestly, or if he really was, feeling a lot better. But I mean, it was kind of immediate, and he was just like, well, I wish I would have had this a long time ago. So, I think all these things, these are all pros. These are all things that we need to take into consideration and know that they're working. Medication assisted treatment does work. I'm a true believer, 100% believer in this, especially with the younger crowd. And then again, it's occupying the same opioid receptor as illicit opioids, so that's a plus in itself. That's basically taking the place of this, right? So you have something that's, 100% less deadly, that's actually working the same way that this illicit substance, in a sense, right? So again, when we talk about pros, these are all pros that really work for the younger population, and if if it's taken properly, then it's going to work, and they're going to recover from this substance. I know we have cons on the other side. We have cons, when we're talking about some teens become dependent on certain medications, and that's across the board. That doesn't only mean it because it's buprenorphine or methadone or whatever it may look like. I mean, that's kind of across the board. I think a lot of us have addictive behaviors, and we act on those addictive behaviors, so it's just it's important to watch out for that as well, because that definitely is a con, and it can happen, to the best of us. They may sell their drugs, they may get, and again, this goes back to what we talked about a little bit about parents, having control over this, because it's something that needs to happen, right? If they don't, then there's a chance that their teen might get them and go and try to make some money. I mean, that's just the fact, so to be monitored and to be doing this the right way, I mean, that's super important, because of the fact that they can be sold. Again, Amy talked a little bit about stigma, so I mean, I think stigma is always going to be around. There's certain people that are totally against medication assisted treatment, and knowing that it's saving lives, I still run into a few that are totally against it. So I think these are just, important, pros and cons. I'm sure there's a whole lot more than that. This is just a few to kind of think about. I think these are super important to pay attention to, because of the fact that they do matter, and it's important to, to pay attention to your adolescents, guys. Pay attention to the younger crowd, and if you do treat them, then again, I'm not special, but I feel like I have a gift, guys. I feel like, and I feel like engaging them the way that they're going to understand, I mean, it goes a long way. It goes a really, really long way. It really does, and just educating them on how they're going to understand it. If you come in with the book and you open this book and you're trying to talk to them out of a book, you're going to lose them. I mean, that's just what it is. It's because this is a different world today, so, yeah. So I think that, do we have any more slides, or is that it?
Or Michael, do you mind if I ask a quick question?
Sure, yeah, go ahead.
Regarding that con of teens may sell or trade buprenorphine, of course that can certainly happen, but I'm curious, in your experience, given that, this is a medicine that prevents withdrawal symptoms, this is a medicine that controls cravings, how frequently have you encountered that? Like, is this a concern that happens really, really commonly, or is it just something to be mindful of?
It's just something to be mindful of. I've seen it maybe once. Most adolescents that take it, they know that it's actually doing something to kind of, reverse the effect, or helping with urges and cravings. So there's not, I think it's maybe one, and it wasn't really selling them. He kind of just was trading them or something like that, so it's just something to be mindful of, because it can happen, but it's not something that happens on a daily basis. No.
I think that's really helpful. Thank you for elaborating on that.
Of course. Thank you. So education and training, I think that, again, I think, there's a lot of things that are changing with CalAIMS. I think, I haven't fully dove into it, to be quite honest with you. There's still a lot that I want to kind of dive into, so I get a better understanding of, what is everything that's changing. But I do know there's a lot of different trainings. I do know that much. So I think, just being able to get in there and educate yourself, especially when it comes to the youth, because that's it's definitely a sensitive topic, and we want to make sure that we're doing all the right things, with the youth, Amy talked about, barriers and ethics, and, so, we just want to make sure that we're actually doing the right thing with CalAIM now, so CalAIM. So, I do know that there's a little bit of a difference with the trainings, but again, I think it's a matter of just diving in there and actually making it happen. And again, we want to make sure that we're providing the correct services for the youth. So is there any more questions? I'm not quite sure how much time we have left, but is there any questions that anybody has that maybe I can help you with, or any concerns, anything of that nature that maybe we can, answer for you?
You have a question in the room.
Okay.
Yes, I'm wondering, are you under the SOAR 2 grant, and with the teens, are you doing the GIPRA survey? And if so, how do you approach the teens on that?
So right now, as it stands, we're only able to provide prevention and intervention right now because of the fact that we just started our nonprofit, and so we have to actually get the building certified before we can provide treatment. But as far as surveys go, I mean, there's they seem to be pretty open to it. I mean, so we actually help out with another organization that actually runs a group once a week, and I think that the more that they come and the more that they're engaged, the more open to it. I mean, it's kind of, you know, they get to feel like, you know, hey, my peers doing this, so it's not really a bad thing, and then it's kind of like word of mouth, you know, you know, hey, it's cool, it's not gonna hurt you, it's not gonna hurt anybody else, you know, just go ahead and do it, it's not a big deal, you know, and it, you know, it seems like it's worked out pretty well that way. And again, I think it's everything comes to the engagement, the approach, you know, and I'm a true believer in that. I feel like, you know, how you approach an adolescent and how you engage them, that's gonna speak volumes for them, you know. So again, I'm a strong believer that, you know, just the approach and the engagement is gonna help out a whole lot.
Also, let me just chime in too. We contacted our local high school. All high schools have their leadership programs and the clubs like after school. And so we contacted a couple. We put like a call out on social media, and 2 students responded. That one was a president and one was a secretary from another club, and they were able to rally all the leadership in the high school and create like a partnership, right? It kind of evolved into a leadership program that we've started here as far as volunteer hours and college, you know, letters for recommendation, and getting them involved from the youth's perspective, and in really getting information on what's going on in the high schools. Our high school here is like a little Chico state, and there's a lot of substance abuse on campus, a lot of alcohol use. And so having them on the team, so to speak, can really push forward surveys. They all are into social media, and so having them use their social media platforms. As far as in-house with the active clients, the contingency management is the best thing next to ice cream if you want the kids to be involved, and having an incentive and just telling them good job and here you go. It's like, you know, a lot of times they'd never hear good job or I'm proud of you. So contingency, a healthy, robust contingency management program that rewards negative UAs or attendance in group really works well with the youth.
So and with that, really quick, you know, so a lot of that depends on the population, guys. A lot of it depends on the population. Or you might have a high school student that's going to be able to kind of engage that way. You might have somebody else that comes from a little bit of a rougher background that is not going to engage that way. So I think, again, it's kind of, you got to remember to meet them where they're at. You know, always meet them where they're at, whatever that's going to look like. The high school kids are awesome, hands down. They're super cool. They're awesome. They're engaged. You know, but they've kind of been doing this work, you know, amongst themselves already. So whereas you get somebody else that's kind of maybe not too engaged and doesn't really want it, and you know, is kind of pushing back a little bit, that's going to make all the difference in the world, you know. And I think that's when I say that, you know, we have to meet them where they're at. It's kind of, you kind of have to find, you know, whatever is going to work for them, you know, because they're all unique in their own special ways, you know, and that's the way I like to explain it. You know, every individual, every adolescent is unique in their own special way, and we need to find that uniqueness, and that's the way that we need to attack it.
And I think too is being open-minded or innovative on how to, again, just how my brain works is utilizing other staff positions. So we use case managers now, peer support, and really finding out how we could bill for that service to support the youth. A lot of it's transportation. Trying to get the youth to and from their session if mom and dad are unavailable. We're a big ag community, so a lot of times the parents are out very late till 6 or 7, and so they've become latchkey kids. And so we've done a lot of transportation and getting creative with positions and utilizing peer support for recovery services. And we're creating a position now, community health worker, that can bill for their services as well. So it's a whole team approach. It's not just the youth getting to the treatment program. It's everything that comes as a wraparound service.
And one recommendation that I have is hire people with real life experience, guys. It really does help. It really truly does help. We need to have at least, one or two team members on the team that's able to kind of bring that, to the kids. I promise you that it'll be life changing. So if you can do that, if you have the ability to do that, please do that, because it is huge, and the children will react towards that.
These kids are crafty. I mean, they'll challenge you. I mean, we had one kid, he's like, he uses fentanyl, and he, he's like, well, I'm not using fentanyl. Isn't it okay if I, go on an acid trip twice a month? And I'm like, no, it's not okay. And then so they're challenging. Well, what do you think about, legislation in Congress and, about psychedelics used in, I mean, they're really smart kids. And I'm like, I don't know. And so they'll challenge you. They have a lot of questions. They know about drugs. So it's not like they're, some kids are opiate naive as far as their system being able to tolerate it. And then there's some kids that are very experienced. We did an assessment that the youth started heroin at 11 years old. The mom was an intravenous drug user. So we just got to remember the different walks of life, different experiences, and they will come with a lot of questions. So it's just being open and honest. And if you don't know, say you don't know. Because if they catch you in a lie, so you got to really build that therapeutic alliance with them.
Great, thank you. Brandy, do you have any other questions in the room? I have a couple from the chat.
I think we are good on the room in the room. Thanks.
All right, great. I just have a couple. We just have a couple of minutes left. Robert's asking if you have any recommendations or where to get more information about dosing recommendations.
I think dosing recommendations, I mean, that kind of has to come from, from in collaboration with the adolescent and the doctor. I mean, I think that's going to be more of a doctor decision more than, than a provider. Yeah. And only because they're going to know what's best for the adolescent, right? It's not going to be something that we can decide for that child.
We also, though, have a lot of partnerships and collaboratives, even in the Tri-County area. And we have doctors willing, like, what do you need from a provider perspective? Because I'm not a doctor. I pretend like I am, but we have doctors that are putting themselves through getting board certified in addiction medicine that want to collaborate. They'll say, hey, if there's a doctor that's uncomfortable, reach out to me and I can connect you with a provider that can do some peer-on-peer work with you. I think providers that are comfortable in this field right now are willing to engage another provider because we need more providers willing to prescribe and feel comfortable in treating in substance abuse, let alone youth and substance abuse. So again, it's just reaching out. If you need connected with somebody, feel free to reach out or reach out to Grant and I can connect you with somebody that would do some mentoring, job shadowing, prescribing with you.
Absolutely. So Robert, if you have more questions for prescribers around dosing recommendations, we're going to post the slides on the conference website, but also we're happy to help you get in touch with Amy and Michael as well. And I think we've got time for one more quick question in the chat. What kinds of, well, you touched on this quite a bit, but what kind of groups are you providing in at your agency? What other services do you think are important in addition to the medicine?
I mean, I think, that's they're going to depend on the population, I think. I think everything kind of comes down to the population, what type of population that you're serving, and that's going to depend on what type of curriculum you should be using. There's so many different types of curriculum these days. It's just a matter of, finding that right one that's going to be for that population. I know Hazleton has some really good curriculums, and so we've used them a whole lot, in the past. And it's just, if you're dealing with the population that's coming out of juvenile hall and criminal justice system, that's going to be a totally different curriculum, whether, rather than somebody who's kind of smoking a little bit of pot. It's going to be two totally different type of curriculum. So it's just going to depend on the population. And again, a group setting is going to be a little bit difficult because you might have different populations in that group setting. So it's just kind of, you have to find the right fit that's going to work for everybody. It's not a one shoe fits all. So that's the kind of, the part that gets a little bit tricky. But the group engagement, when it does work as a group, as a whole, it's awesome. So I think it's just a matter of finding that one curriculum that's going to work for that certain population. I can't really specify one specific one. Sorry.
We do use Matrix, obviously the updated version. We have the youth one and the criminal justice one. We use that. We do family group. So the kids go in one session, the parents are in another session, and then we bring them together for a group session. We've used that at the county. Just a lot of things. I think you have to be creative too. We do incorporate a lot of treatment into prevention, even though we don't call it treatment. We're doing prevention. It all correlates the same. We use a lot of online websites now. I don't know if you guys have heard Song for Charlie. Song for Charlie is a website that gives you templates and formats to do school presentations, facilitate trainings. They'll give you handouts like group sessions on marijuana. Here's a 6-week course on marijuana. This is let's talk about opiates. This is a 10-week guided discussion on opiates. So Song for Charlie is my go-to. I know I'm not supposed to plug anybody, but a lot of information. A Drug-Free Now World is another one, but those are useful ones that you can just go on the web and click and print versus doing a binder and curriculum. I think those kind of days are over with the binders because everybody loses them and then nobody logs in, and so you got to get creative. And we just go with really CBT, MI, contingency management.
Well, thank you very much, Amy. Thank you very much, Michael, as well. We really appreciate your presentation. We also really appreciate your flexibility, especially under the circumstances. So thank you very much for presenting.
Thank you for having us. We really appreciate it, Grant.
I should get a $5 gift card. During COVID.
Absolutely, absolutely. Thank you all very much, and thanks everyone for joining.
Yes, thank you to everybody. Appreciate it. Thank you, guys.